Good afternoon to everyone. I'm honored to be here and to have the possibility to present the first webinar organized by the EFIM Rare Diseases group that was formally launched just 1 year ago in 2025. The aim of our group is to strengthen the role of internal medicine in the management of rare diseases and our group decided as identified the education is our first priority because we are convinced that the formation and information are fundamental steps to shorten the diagnostic delay. So we will organize a series of webinar, very practical, on different rare disease directed to frontline internists. Today we will talk about hereditary angioedema, and the webinar will be divided in three parts. The first speaker will be Professor Hassan Messaoudi, an expert on hereditary angioedema, working at Mohammed Boudiaf University. I'm not sure that the pronunciation is right, in Algeria. And he will talk about, he will present a clinical aspect of the disease. Then I will talk about the management of hereditary angioedema. And last but not least, Professor Markus Magerl, a very big expert on hereditary angioedema, professor and head of the clinical trials department at Institute of Allergology at Charité in Berlin, will present his vision of about the future of treatment and management of the disease. Please, Professor Messaoudi, it's your turn.
Thank you very much, dear colleagues and friends and distinguished listeners. I'm delighted to be with you. I'm very happy to talk about rare and potential hereditary disease with the expert, Dr. Maria from Italy, and Professor Markus from a big expert like Maria. In the hereditary angioedema, I have already seen them in many events. So I think that there is a little bit of mistakes. I effectively am Professor of Internal Medicine from Algeria, and I work in Department of Internal Medicine, but I am not in my university. Since last year, we have a new university, the first and the unique University of Science of Health in Algeria, which called Mohammed Yusuf Al Khatib. Thank you very much. So we are talking about a rare disease, which is hereditary angioedema. Let's go starting. So at the beginning, I have no conflict of interest. I think that the aim of this learning objective is by the end of this presentation, participants should be able to define hereditary angioedema. This is a reason why we have organized by this working group this hereditary angioedema. So recognize the clinical warning signs suggestive of HAE. So differentiated HAE from allergic angioedema. This is the most problem because we have less than 5% of swelling, which is only bradykinin produced, but we have more than 55% of angioedema secondary of mast cell. So also we have to identify key diagnostic test, and as you know, understand when to refer patient for specialized evaluation, because usually patient come to the emergency and they see the general practitioner. Sometimes the general practitioner needs and have to send this patient to the referent doctors. So, as an introduction, hereditary angioedema is a rare genetic disorder. So it's autosomal dominant.
Excuse me. Do you want to use your slides? Or, I don't know.
Yeah, of course, yeah.
Okay, because we now.
You don't see our slide? My slide?
No, we can't see your slide.
Okay, I
You have to share it if you want.
Yeah. All right.
Okay. Now it's okay.
I repeat. So I said in the beginning, the learning objective of this webinar of this working group disease is to, by the end of the presentation, participants should be able to define hereditary angioedema. As I said before, hereditary angioedema is a rare disease, so we have only less than 5% of swelling, which is a relation with bradykinin produced. So at the beginning, to define hereditary angioedema, Then recognize the clinical warning signs suggestive of HAE. Then differentiate HAE from allergic angioedema, and identify also key diagnostic tests by using the complement system. And sometimes we have to do the genetic testing. And at the end, we have to understand people, general practitioners have to understand when to refer this patient for specialized evaluation. I said that usually patient, I think in many places, in Algeria particularly, patient come to the emergency and they usually saw the general practitioner. That to this presentation will show to the general practitioner when we need to refer this patient for the specialized evaluations. Introduction, hereditary angioedema is a genetic disorder. Everyone know that. So it is an autodominant disease. It's characterized by a recurrent episode of angioedema and potentially life-threatening due to a laryngeal edema. This is the most problem. And this disease is often underdiagnosed or misdiagnosed for many years. Epidemiology, prevalence, we have approximately 1 in 50,000 individuals. Usually, studies say that this disease affects male and female equally, but some studies reported that we have slight female predominance. Usually, this disease begins in childhood or adolescence, and we also usually have positive family history in most of cases. So what causes HAE? Physiopathologic, most cases of HAE is caused by deficiency or dysfunction of C1 inhibitor. And we have secondary excess of bradykinin production. And at the end, we have increased vascular permeability. So this diagram shows the pathway involved in bradykinin-induced angioedema, including HAE with or without C1 deficiency. So this diagram shows the bradykinin pathway involvement of hereditary angioedema and explain how deficiency or dysfunction of C1 inhibitor. So the factor 12 becomes activated to factor 12E. So this factor 12E convert prekallikrein to kallikrein, and this kallikrein cleaves higher molecular weight kininogen to produce bradykinin, and this at the end, this bradykinin being the beta 2 receptor on blood vessel, at the end we have increases vascular permeability, and which is causes edema or angioedema. But what is the role of the C1 inhibitor? So as you know, C1 inhibitor is crucial in this pathway, in this diagram. Why? Because normally it inhibits factor 12A and kallikrein and some part of the fibrinolytic and complement system. When this C1 inhibitor is deficient, unchecked kallikrein activity occurs, and we have excess of bradykinin is produced. At the end, we have recurrent angioedema develops. So we have the main type of angioedema. We have type 1, where the C1 inhibitor level is low. We have account for 85% of cases. And we have type 2 in C1 inhibitor deficiency. We have normal, the C1 inhibitor is normal. Sometimes we have a little bit elevated, but we have the protein dysfunction, and which we can find that in 15% of cases. And we have the third one, which is very important, which is hereditary angioedema with a normal C1 inhibitor. This is often associated with new mutation in factor 12 at the beginning by when Bork has discovered in 20,000 a new mutation, which he has found that there has a new type of hereditary angioedema. They have the same symptom, but the complement system was normal. So in 2006, he's found the first mutation, which enable factor 12. So, what is the clinical manifestation? At the beginning, we have cutaneous edema. This is the reason why the most manifestation without pitting, without paralytic, which is slowly progressive. And we have usually the swelling is in the tongue, in faces, and in genital. We have also gastrointestinal attacks. This manifestation can mimic acute abdomen and sometimes appendicitis and intestinal obstruction. And we have also the upper airway attacks, which is a medical emergency. And usually we have mortality risk increases without prompt treatment. So when we have all this symptom, we have to do initial laboratory tests. We start usually with C4 level, which is when in most cases and the good screening test positive. So, but we have in 10%, we have where the C4 level is normal. So we have to do C1 ENH quantitative level, and when we haven't any, in some countries we haven't any C1 inhibitor function, but we have, if we haven't, we have to do C1 inhibitor function away. And sometimes it is not necessary to do C1q level, it's just to differentiate acquired angioedema. So in this case, we have to do the genetic testing in selected case. Prodrome, sometimes people with hereditary angioedema have prodromal symptoms. We have fatigue, mood changes, and we have most of the manifestation, which is erythema marginatum, which is a serpiginous thrush, no paralytic, and is often confused with urticaria. We have also typical triggers, common triggering factors: stress, traumatism, dental procedure, surgery, infection, hormonal changes like pregnancy, estrogen-containing contraceptive as ACE inhibitor. But we have to know that sometimes attack may also occur spontaneously without trigger. This diagram shows us the hallmark feature subjective of HAE. We have a key characteristic when we have what is the difference between HAE and allergic angioedema. Urticaria is usually absent in HAE and is present in allergic angioedema. Itching also is usually absent in HAE and is usually common in allergic angioedema. We haven't any response to steroid and antihistaminic in HAE, but we have usually response in allergic angioedema. And as you know, usually we have family history in hereditary angioedema, and we haven't any in allergic angioedema. But I think that the most, when we serve people in hospital, we usually ask the question, the attack duration. Usually we have less than 24 hours when it's concerning allergic angioedema, but you have more than 24 hours, 2 to 5 days duration of attack. So when should you suspect HAE? At the end, when we have recurrent angioedema without urticaria, swelling of face, lips, tongue, extremities, genital, and also when we have recurrent abdominal pain, we have sometimes severe colic pain, vomiting, diarrhea, and ascites. And we have also laryngeal edema with dysphagia, dyspnea, potential airway obstruction. And usually we ask the people if there is any family history, similar episode in relative, and sometimes we can find sudden unexplained death in the family. Why is HAE frequently missing? Because the diagnostic is delayed. This is the reason why the HAE average diagnostic there is between 8 to 15 years in many studies, and some studies and in some countries when genetic testing and misdiagnostic, we have more than 20 years. Reason for misdiagnostic: symptom mimic allergy or anaphylaxis. We have abdominal attacks mistaken for surgical emergency, like appendicitis. We have lack also of urticaria, confuses cognition, and as you know, hereditary angioedema is a rare disease. Yeah. Then limited awareness among healthcare professionals. So what is this? This picture is taken from one of my patient. What is the HAE normal C1 inhibitor? Because usually when we suspect hereditary angioedema, and when we do complement system, and when we haven't any perturbation in this biological, then we stop and we said there is no, it's false. So we have a type of hereditary angioedema with normal C1 inhibitor. When we have recurrent episode of angioedema, when we have absence of urticaria, we haven't any hives, and when we have usually normal C1 inhibitor level and activity. So in this case, we have to do the genetic testing by looking gen associated with HAE, 12-factor, PLG, angiopoietin, kininogen, myofilin, HS3, ST6, CP1, and DAD2-EB. K-point, significant genetic heterogeneity, variable clinician expression. Some patients have no currently identified mutation. So at the end, we can say to our colleagues that hereditary angioedema with or without C1 inhibitor deficiency, they have typically the same symptom. Diagnostic approach in HAE with normal C1, we have usually clinical criteria. We have recurrent angioedema without urticaria. We have positive family history. And laboratory finding, we have normal C1 inhibitor, function, and antigenic. In this case, we have to do the genetic testing. So the diagnostic, the differential diagnostic in HAE with normal C1, we have histaminergic angioedema, we have acquired angioedema, we have ECE inhibitor-induced angioedema, and we have idiopathic non-histaminergic angioedema. So we can say that HAE with normal C1 inhibitor represent a heterogeneous group of disorder sharing a common endpoint, is increased vascular permeability and recurrent angioedema. So this slide shows the last classification of hereditary angioedema in 2025, which divides bradykinin-induced angioedema. It's a little bit different from the previously. We have C1 deficiency with hereditary angioedema and acquired angioedema, and we have normal C1 inhibitor, which with mutation 12-factor, PLG, kininogen, myofilin, and we have on our right of the slide VGF-induced angioedema, and we have also mast cell mediator-induced angioedema, including angioedema with urticaria, with EG mediated or without, and at the end we have also a known mediator. Till today, some hereditary angioedema still without causes, and they are called a known mediator, idiopathic angioedema. So red flags in daily practice. Think about HAE if you see recurrent swelling without hives, repeated emergency visit, unexplained recurrent abdominal crisis, intubation history due to edema, poor response to antihistaminic and corticosteroid, and also family history of angioedema, and when we have recurrent edema after dental procedure. So the differential diagnostic is conditioned to exclude histamine-mediated angioedema, allergy, anaphylaxis, acquired angioedema like lymphoproliferative disorder and autoimmune disease, drug-induced angioedema like SCA inhibitor, and we have also other causes like idiopathic angioedema, mast cell disorder. The diagnostic, the algorithm is we suggested approach when we suspect HAE clinical, we have to do measure serum C4. But it's better if we do C1 inhibitor function directly. If low, in some countries, this test is not available. So we start doing C4 level. But when it's available, it's better to do directly C1 function. We measure C1 level and function. We confirm the diagnostic, and we refer to immunology, allergy specialist, internist, or dermatology. In conclusion, what is the final message? So I can see that think beyond allergy when evaluating recurrent angioedema, because early suspicion of hereditary angioedema can save lives. Thank you for your attention. I think that I have respected my time, which is 20 minutes. No, Maria?
Yes, you have.
Okay, Markus? Thank you.
Okay.
So I think that we will move to the second presentation.
Yes, if you can put away your presentation, I can
Of course,
share
yeah, of
mine.
course, of
Thank
course,
you.
yeah. Let me
Just,
1 minute,
uh,
please. Okay.
okay. Thank you.
Okay. So now I want to introduce my colleague and friend, Dr. Maria. Is an expert from Italy to present the management of hereditary angioedema. So we are listening to you seriously.
Okay, thank you very much, Asen. And I'm very happy today to talk about hereditary angioedema, not just because it is my principal area of interest, but also because, as Professor Messoudi explained, this disease is very complex and can have a multisystemic presentation, very severe in some cases with abdominal and high airway involvement. So the internist can represent the first approach for many patients. And I think it's fundamental to know this disease, to suspect it and to shorten diagnostic delay of our patients. During my talk, we will approach the management of hereditary angioedema, that is, as we will see, not just strictly the therapeutic approach, because these patients are very complex and they need a lot of attention from many points of view. These are my potential conflicts of interest. I begin with the presentation of this slide just to underline, as Professor Massoudi anticipated, that nowadays to talk about the management of hereditary angioedema is not just to talk about the C1 inhibitor deficiency, because in the last decades we had a very, very rapid discoveries of new kinds of angioedema, of new genetic diseases. And so when we talk about the management of hereditary angioedema, we don't talk just about the C1 inhibitor deficiency that we know quite well, but also we have many nosologic entities inside this description. Also, if we talk about the hereditary angioedema with normal C1 inhibitor, they involve many different diseases with many different approach pathogenesis, and so it is very difficult, and I think we will have more and more details about them, and in the future I think we will have to split up these different entities, but now we will talk about them all together. And I present a different nomenclature that is not the last one about WHO presented by Asen, but this one that is dense, just to underline that from my point of view, what is very interesting in this new nomenclature, this one and also the one about WOW, is that there is a division between the bradykinin mediated group and the vascular endothelium group, because my feeling is that they are very different, and probably they are different also in the management and in the possibility to treat them with the drugs that we use in our daily life for patients with C1 inhibitor deficiency. And my agenda is this is the agenda of my talk, of my brief talk. First of all, I will talk about the management of HA with the C1 inhibitor deficiency. We have had a very a revolution, a complete revolution in the last decades, with a lot of new drugs available, and they are very effective, very safe. So thanks to them, the goals of our patients and our goals are completely changed, and we will talk in detail about it. Then a brief focus on HAE with normal C1 inhibitor. As I said, we have very few data about this kind of angioedema. And recently, it was published a consensus document about the management of these patients, but it is more based, mostly based on expert opinion than on trials. But I will present it because it is interesting to indicate a pathway to to all the colleagues that treat these patients. In the last part, a brief, very brief, just a few slides about a focus on pediatric population, because just some weeks ago was published a paper with the guidelines on the management of pediatric population of patients with hereditary angioedema, obviously. These are the EACI guidelines of 2021, 21, sorry. And as we will see, the first approach for the management is obviously the therapy. The therapy that is, we can divide in three moments, three different moments. The first one is on the on-demand therapy, that is the treatment of the acute attacks, that is fundamental, and that all the patients have need to have this kind of drugs at home at every moment, because as Professor Sodi said, this disease can be life-threatening if the attack involves some location like high airways. Then the long-term prophylaxis that is intended for was intended at the beginning for very severe phenotypes, but now, as I said, the situation is changing, and the short-term prophylaxis that is used just in specific situation, we will see. But also, it's not the management is not just therapy, but also general support to our patients to face their daily life. That is very burden for our patients. In fact, we have a lot of papers now that have studied the burden of the disease on the daily life of patients, on their progression at work, on their mental status. This is this paper from Lamry is one of the first that was published in 2010, and he demonstrated at the time that he used some standardized instrument and comparing the normal population with the HAE patients, and he demonstrated that the patients with HAE had a depressive symptomatology more than the normal population. The difference is very important, and that the severe symptoms were connected, the severity of the disease were connected with also severity of depression, of an alteration of mental status. So depression increases with attack severity, it is true, and it is also confirmed from by other articles. This is more recent, for example, by Alina Banerjee, and they demonstrated, they observed also some particular situations that are not always connected with the attacks, but also the period. It is confirmed that the period between the attacks, it also a burden, because the patient every day have a fear that an attack can arrive in every moment. So they have fear for the stigma. They cannot think about the future because they always think that an attack can arrive. This is very interesting for us because we live with our patients this problem, and this is for me, from my point of view, a very interesting paper that was published recently from Professor Magerl group, and in this paper they confirmed that this disease is very a lot of consequences on the quality of life, but they add the fact that the observation that just a complete attack freedom rather than partial control is necessary to have a normal life. That is to say that our goal, if possible, is not to have few attacks, but to have zero attacks. And this is why I say that the paradigm of our point of view, our and also the patient point of view, is completely changed because now our target is the normalization of life with zero attack. This is also another very interesting and very comprehensive paper that was recently published, an expert consensus from a European committee in which some expert describe the pathway to reach a treat to target to have a treat to target approach to our patients, and they delineate as the first goal in just few months, 3-4 months, and improve the ability to have normal daily activities and also a reduction of the number of attacks. But on the long term, so they propose 6-12 months, but also more than 12 months, but not at the end, and I agree, the goal is the normalization of life, what we call an attack-free life, so zero attacks. This is completely changing our point of view, and also sometimes in my experience it's difficult also to convince patients, because all patients that in the past, some decades ago, they were convinced that to use that the importance was to use the drugs just for life-threatening attacks. Now the situation is completely changed, and it will be clear, I think, for young people more than for the old people that have a different idea about the management of this disease. But in general, the first step of the approach of the disease is the on-demand therapy. And these are the recommendation of the guidelines. The authors recommend that all attacks are considered for treatment, not just the very severe or the one involving abdominal organs or high airways. But obviously, any attacks are very severe have to be treated, not just considered for treatment. And this is something that is now sure, proved by many data. It is important that the attacks are treated as early as possible. Not all the patients are able to do this, but it's important that the doctors at every visit try to convince the patient to treat the attacks as early as possible, and all the attacks, because we know that sometimes the attacks can involve more than one location, and can arrive, for example, to high airways, also for contiguity. So it's important to treat and to have also always available the drugs for on-demand therapy. The drug that we have at the moment are intravenous C1 inhibitor, plasma derived, that is for endovenous administration. Ecallantide is not available in Europe because of its potential risk of anaphylaxis, but it is used in USA. And icatibant. Icatibant is a drug that is administered subcutaneous now. A lot of patients use this one because it is very easy to use even outside the home, and so yes, it's a very good the drug, and very safe. And the recommendation of the authors is that every patient need to have at home the treatment for at least 2 attacks, because the attacks can be very one day before and one day after. So it's important that they have enough drug to treat at least 2 attacks, and to have the drug with them at every moment. And this is a very important point for me and for all the colleagues treating these patients, is that all the patients need to be trained for self-administration. This is a concept that we introduced some years ago. In fact, this is, for example, a report, a paper that we published, our group published more or less 10 years ago, and in which we began to train patients at the beginning. We noticed that patients with high frequency of attacks were more prone to learn to be trained for home therapy. But now that more drugs are available, that we have also subcutaneous drugs, I can say that most of patients can self-administer, or someone in the family can, so a caregiver, for example, can administer at home the drugs. This is very important. And we also demonstrated that it's important for the patients, for the quality of life, to treat the attack as early as possible, but also from an economic point of view, because there are lower costs for the patients and also for the health system, both direct and indirect costs. So this point is very important from my point of view. This is the algorithm that proposed by the expert European group, a treat to target algorithm. They advise to assess the patients the efficacy of the on-demand therapy at every visit. At every visit, we have to understand if it is enough or if the patient want or is or needs to begin also the longer term prophylaxis. There are a lot of discussion about which is the patient that need the long-term prophylaxis. This is the answer is not so clear because it depends on the characteristic of the patients, not just on the frequency of attacks or on the localization of attacks that are obviously important. The phenotype is important, but also the kind of work of patients, the approach, the quality of life. And so we have to talk to them and to decide when to begin a long-term prophylaxis and to retalk about it at every visit to understand which patients can begin or need to begin it. Then the short-term prophylaxis, when to do it. It is obviously, when we have a trigger, Professor Massoudi talked about the trigger. There are some situations when that are sometimes different from patient to patient when they have more frequently attacks. In general, all the patients should be educated about triggers that may induce attacks, but they can be very different. This is a paper published some years ago by the Hungarian groups. And they describe that not just some scientific or easily identifiable situation can be considered trigger, like dental procedures, medical procedures, surgery, and so on, or the use of some drugs like estrogens or like ACE inhibitor drugs, but also some different situation like mental stress that it is very difficult to define, or weather changes. This is what patients describe like trigger, but in my experience it is true because a lot of patients describe angioedema attacks during their marriage or in the day of exams and so on. So when to consider the short-term prophylaxis, I suggest, and also the guidelines suggest to use it before the exposure to patient-specific angioedema-inducing situation. It depends on the specific patients. The drug we have available are a lot now, berotrastat, donidalorsen, and so on. I will name them, but until now we have these are the Canadian other guidelines that were published recently, so include all the drugs we have available now at the moment. But I think that the next step will be the understand which patient is best for which which drug is best for which patient. Now these guidelines describe propose all these drugs like first line therapy. Berotrastat, that is an inhibitor of plasma kallikrein with oral administration. Donidalorsen, that is very, very new, and it is an antisense oligonucleotide. Garadacimab, that is a factor 12 inhibitor. And lanadelumab, we have lanadelumab and berotrastat from more time, so we have experience with them. This is a monoclonal antibody that inhibits plasma kallikrein. They are safe, they are effective. So, as I said, the future is very better. The future patients will be treated easily, and they will have a good future, I hope. These just a few words for the hereditary angioedema with normal C1 inhibitor. This is in a consensus paper based on expert opinion more than data. We have not clinical trials, and we have a lot of different kind of disease, sometimes with one family or two family described, so very few patients to have certainties. But what we can say for the management, to the advice is to discontinue estrogen-containing medication and also ACE inhibitor drug. To use in this patients, it seems that prophylaxis, that tranexamic acid can be useful for prophylaxis, and then the expert, this group, I was in this group, we decided to advise to use more or less the same drugs that are used for the patient with the C1 inhibitor deficiency. But it's very difficult. It's difficult because in some countries there are not possibility to gen sequences. Some patients have not a mutation, but the advice is that also if there is a presumptive diagnosis, we have to prescribe this drug, because an attack involving a high airway can be life-threatening. It is very difficult from my point of view for patients, above all in some countries where it is difficult to prescribe these very high cost drugs. Just a few words for the management of pediatric patients. I will not talk about the drugs because most of us are internal medicine internal doctors and not pediatricians. But I think it's important the point of view of this group, because they advise a comprehensive care center where adults and children can be treated all together in a family, because most of our patients are family, are all affected by this disease, and to pay attention to early transition. And also to have regular education to these patients with the written information and education material. This is what we have obtained, but I think that Professor Magerl will talk about what is a big unmet needs from my point of view. That is the next goal, the next dream that we have, that is to have a cure and not a treatment. At the end, I want to thank our EFIM working group. In the forefront, there is our chair, that is Professor François Maillot. I don't know if my pronunciation is good. And I also would like to thank FADOI, that is the Italian Scientific Society I am representing. And also I thank my colleagues, the nurses, and the basic immunologists I'm collaborating with. And I thank you for attention. Okay.
Thank you, Maria.
Okay.
I introduce, or you do it for Markus?
Introduce, please.
Okay, thank you so much, and it was very interesting for your talk and your speech. Yeah, it is an opportunity to thanks. We miss really Professor Nicolas François from Tours, our chairman for the working group disease. So we will move to the next and the last speaker, which is Professor Markus Magerl, our big expert from Germany, and we are very happy to listen to you clearly. So we are listening to you, Professor Markus. Your microphone is closer.
Oh,
yeah, okay.
It's better now, no? I started that I'm very happy to get this invitation. And while you were talking, and Maria, I checked the names of the participants, if I know somebody, and I was excited to see that there was only a little number of people I know. So obviously, this topic, angioedema, hereditary angioedema, has an increasing popularity And so I'm very happy about that. Maria announced that the future will be a cure. I will talk about the near future, and I will tell you a little bit how close we are to a cure. And it's amazing how many developments has been came to market in the last 5-6 years. And 6 years ago, I thought if all these developments are on the market, there is nothing to do left, but there is always something to do. There is always something to improve. And I can tell you that the pipelines are quite well filled, and we will have a couple of new drugs in the next years, hopefully, and I will show you what we have. At the moment, just to make you a little bit familiar with the mechanism, you have heard that the HAE is caused by bradykinin, and the bradykinin is generated by kallikrein. And kallikrein, it's activated, auto-activated and activated by kallikrein. Factor 12 then activates to factor 12A, and factor 12A activates pre-kallikrein to kallikrein. That's important to know, because I will tell a little bit about the drugs and their targets in this cascade. And nowadays in 2026, we have quite a lot of drugs. Many of them were mentioned by Maria. We have an on-demand treatment currently using sebetralstat. It's an oral kallikrein inhibitor. We have the C1 inhibitor replacement intravenously. That's what's lacking most of the HAE patients. And we can use icatibant for on-demand treatment. And Maria mentioned shortly ecallantide in the US, but it doesn't play a big role. But these are the drugs we currently have on demand. On the other hand, we have prophylaxis, and the prophylaxis is targeting for kallikrein, pre-kallikrein, and factor 12 currently, using different techniques like oligonucleotides, C1 inhibitor replacement, monoclonal antibodies, and small molecules which were designed to block the kallikrein. That's what we have at the moment. That's quite a lot. It's much, much more than 8 years ago. And we shouldn't be grateful that we can offer our patients such a bunch of treatments. And currently, we can't complain too much about the efficacy of the treatments we have available, about the safety, and also about the convenience. All of these points have improved so much in the last years, but I told you there's always something to improve. We can even get better with our treatments, with a super safety and a perfect convenience. And I will tell you how this will look in a couple of years. There is a lot, and that's far, far above average of any other rare disease. So the rare disease hereditary angioedema is exceptional in its research activities, and I'm quite sure that's in parts due to very engaged people like Hassan and Maria, and many of us are finding this field very interesting and are working and have fun with doing research. And that causes that there are plenty of new drugs under development. I show you here the oral drugs under investigation. There is, for example, a bradykinin antagonist, an oral bradykinin antagonist, a tablet you can take for acute treatment. That's called deucrictibant. Here it's still called Pharvaris 022121. The same drug can be used for, or will be used in the future for prophylaxis as well. Other drugs, I can't tell about all these drugs, the time is very limited. And we have parenteral drugs under investigation. In the following, I will talk about some of them. For example, STAR 215, for example, that's now called navenibart, or Intelia 2002. Super interesting, as well as the BW285. You will understand these crazy abbreviations in a minute. I talk about navenibart. Navenibart is a monoclonal antibody directed against plasma kallikrein. Basically, it has the same target and the same mechanism like the lanadelumab, which is on the market for 6 years and became some kind of gold standard in the last 6-7 years. However, in navenibart, the FC fragment was modified, and so the navenibart has a super long half-life of 117 days compared to, I believe, 14 or 17 days of lanadelumab. It's also given subcutaneously. However, it's not given in an interval of 14 days or 28 days, but the model calculations show that it could be given every 3 months, 1 injection every 3 months. And other models show that if you adapt the dose, you may increase in the future the interval to 6 months, 1 injection every 6 months. It's a treatment in the summer, it's a treatment in the winter, and all your treatment is done. And real life, not modeling now, real life shows that could be possible. There was a clinical study. It was a phase 1b/2 trial, and patients got navenibart in different doses and in different intervals, but not more than 2 times. The cohort 1 got navenibart, 450 milligrams, only once. The cohort 2 got navenibart, 600 milligrams dose and a 300 milligram dose, 84 days, that means 3 months apart. And the cohort 3 got the navenibart 600 milligrams twice in 28 days apart. And that's what it looks like, the navenibart concentration in the blood. And you see, according if the patients got 1 dose or 2 doses, we see at half a year later, there's still a significant amount of navenibart in the patient's plasma. And with a high dose, the 600 milligrams, we come to 9 months and more, where navenibart can be seen in the blood, can be detected in significant amounts in the blood. And we look for the cleaved high-weight molecular kininogen. This is a measure for the activity of the kinin system. We see that the activity of the kinin system, the system that produces bradykinin, is dropping down very, very strong after giving navenibart 1 or 2 times, and you see that half a year later, the reduction of the activity of the kinin system, the reduction of the cleaved kininogen, is significantly low, and it recovers only very, very slowly. Half a year later, there's still a significant reduction of the cleaved kininogen. This is a first trial, and please have in mind it's not placebo-controlled. It's the data on the right, the 84% reduction is versus baseline, 84% less attacks than in baseline, 90% less attacks than in baseline, and 92% less attacks than baseline, according the different cohorts, and showing that most of the people, most of the participants are symptom-free for a significant time course after having these 1 or 2 doses of navenibart. And this translates to an improved quality of life. You see the spider graphs on the left side, the different cohorts on the top, cohort 1, cohort 2, cohort 3, and you see baseline quality of life, that's the outer ring, and you see the inner ring, that's the current impairment of quality of life, and you see significant changes. So you see a significant reduction in the impairment of quality of life in all domains these measurement has, and these domains are functioning, fatigue and mood, fears and shame and nutrition, and the total score. So very significantly reduction of impairment of quality of life. Maria was talking about a cure, and I think this is the closest, or the drug that comes closest to a cure. That's a CRISPR-Cas9 treatment. It's a one-time treatment. It's a single infusion that lasts 2 to 4 hours, and with this single infusion, the patients get lipid nanoparticles. And these lipid nanoparticles contain the CRISPR-Cas, they are targeting to the liver. So it's not a viral vehicle, but it's a lipid nanoparticle, and via the LDL receptors, they find their way to the liver cells. They are engulfed in the liver cells. They free their content. The content goes to the cell's nucleus, liver cell's nucleus, and targets the pre-kallikrein gene. And it makes a frame shift mutation in the pre-kallikrein gene, causing that the pre-kallikrein can't be translated to a protein. And there were there were 2 studies with a different of dosing, but the latest data is available about the most efficient dose. And the most efficient dose is the 50 milligrams dose given one time. And I will talk in the next slides about the 50 milligrams dose. This is the plasma kallikrein in the patients who got the 50 milligrams a single time. And you see 1 month later, there's a reduction in kallikrein by 85%, and after 2 months we come close to the 90%, and this close to the 90% reduction of kallikrein is sustained for, have a look at the month, that's incredible. That's a year after a year, no recovery. That's 2 years, no recovery. 3 years, no recovery. A single time treatment reduces kallikrein activity significantly. And when we look at the change these over time, phase 1 and phase 2, we see 94% reduction in the first 12 months, and the 96% reduction in all the following months after 1 year. This is the patient's line. Every line is a patient. The patient started their study one by one, one after the other. And we see on the bottom, we see a single non-responder. All the other patients responded. Some of them continued their long-term prophylaxis. They were allowed to continue long-term prophylaxis, and some of them did, but then they stopped. They stopped. Some of them had continuing attacks, but then they stopped long-term prophylaxis. And other patients immediately stopped long-term prophylaxis. And if they had long-term prophylaxis or not, all of the patients now are symptom-free and have no more attacks, and that's an amazing result. That comes very close to a cure. BW2805, completely different thing, very amazing development as well. It's a next generation small interfering RNA treatment. It also targets to prekallikrein, however, with a different technique. It's not a genetic treatment, however, it's working on the level of the messenger RNA of prekallikrein, and it uses the RNA interference to block the mRNA of plasma prekallikrein. It's GalNAc conjugated. That means it's very similar with the gene therapy. It targets the liver cells via the LDL receptor. And I show you some data of an ongoing study. It's an open label study, multi-center phase 2 trial. 18 participants were randomized and dosed in 3 different groups. 6 patients received 600 milligrams every 24 weeks, every half a year. Another got 300 milligrams once per half year, and another got 300 milligrams every 3 months or every 12 weeks. We have data from 16 patients that have data beyond day 29, and from 17-day patients I can show post-dose pharmacokinetic data. That's what we see after the start in these patients. We have the dose 600 milligrams every half a year, and we see there's a 99% attack reduction. It's not against placebo, it's against baseline, but still 99% is amazing, and 83% of the patients are completely symptom-free. With a dose of 300 milligrams every half a year, we have 93% reduction and 60% symptom-free. And with a dose of 300 milligrams every 12 weeks, we see 95% reduction in attack rate and 60% of the patients symptom-free. We see with a high dose, we see a 90%, 96% reduction in the plasma kallikrein levels at day 85 after 3 months. And we see in the lower dose, we see still more than 94%. And when we look beyond the day 85, when we look at day 169, the reduction of the prekallikrein is plasma kallikrein exceeds 90%. So it's a very stable treatment, and across all the dosing groups, and that demonstrates that there's a very robust suppression in after half a year dosing, and that means that maybe even longer intervals could be possible. With this, at least 6 month interval is absolutely justified. The BW2805, no adverse or severe adverse events were seen, and it's very, very well tolerated. And most common adverse event was an injection site reaction, mostly mild, just a redness or a little burning. Other drug, very interesting as well. It's an oral drug, and this oral drug can be used on the left side for long-term prophylaxis with an extended release tablet. On the right side, we can use it also as in the future as an on-demand treatment. Very nice and smart approach to have one drug for long-term prophylaxis and for on-demand treatment. It's called deucrictibant. It's a molecule that blocks the bradykinin B2 receptor. And just showing a little bit data, the latest data published in April 2026 about the long-term prophylaxis. It's a very busy slide. It just should tell you that there were 11 patients assigned to deucrictibant 20 milligrams a day, 12 patients to deucrictibant 40 milligrams, and 11 patients received placebo. And the data I show you is from the phase 2 trial. We see the patients with 20 milligrams daily on the top. In the middle, we see the 40 milligrams dosing, and at the bottom, we see the placebo. And each point on the line is an attack. We see plenty of attacks in the placebo group. We see a small number in the 40 milligrams group in some patients only, many of them completely symptom-free. And we see the same, very similar pattern in the 20 milligrams group. Most of the patients, no attack at all. Some of them, this one seems to be kind of non-responder, but in total we see 79% reduction in attack rate in 20 milligrams and 85 in the 40 milligrams. And that's not against baseline, that's against placebo. On-demand treatment, on the left side, it's a super busy slide. I translated it, or that's a translation. On the right side, the patients got treated 3 attacks with either 10 milligrams or with placebo. That's it. Very clear study design, and here is the result. And this is the percentage of attacks with rescue medication. So patients have an attack. Patients were told that they should use their study medication, their IMP. It was 10, 20, or 30, not 40, sorry, 30 milligrams, and or placebo. And patients were told, if you don't have a good feeling after 4 hours, you are free to take your rescue medication, your traditional rescue medication. And look at the gray line, the placebos. Some of them couldn't wait the 4 hours. Some of them took their traditional rescue medication. And after 4 hours, most of the placebo patients very quickly took their on-demand treatment, their rescue medication, their traditional. More than 2/3 of the patients took it in a few hours. And here the patients with the 10, 20, 30 milligrams deucrictibant, some of them did in the lower dose especially, but most of them trusted and enjoyed the treatment and enjoyed the effect. And this is the very recent publication, 26 as well, from a poster they published. The primary endpoint of the study was the onset of symptom relief. And we see here the comparison placebo and the verum. 50% of the patients with the deucrictibant had symptom relief after 1.28 hours compared to placebo. They never reached it not in 12 hours. So very encouraging data. So when we look 26 and beyond what we have in the future, then we have a couple of drugs in the pipelines. And I didn't tell about all of the drugs, just a selection that are close to be mature for market. These drugs target all the parts of the kinine cascade, and I think that when we look on our patients today, I'm very sure our patients are much better off today than 6 years ago. Many new drugs mentioned by Maria have started in the last 6 years. However, I believe that in another 6 years later, the patients hopefully will be even better feel better than today with the new developments. And I'm fascinated how many developments are there for this rare disease, how many different targets are used, and the variety of the techniques used to meet these targets is absolutely amazing. And so I believe that the new developments close gaps we still have and promise further improvement for our patients. Thank you.
Thank you.
Thank you, Markus.
You're welcome.
I think we have just one question from Francois, our chair. Let's say, could you please give some details on how you educate patients with the HAE?
The question is for whom?
Yeah, I mean the education of patients, yes, I mean to recognize early symptoms, but also to convince them, because sometimes the compliance is low with some patients. So I educate, I mean to have always with them the drug to treat attacks, so and on the on-demand therapy, and to use it because sometimes they tend to avoid to treat the mild attacks, or they treat attacks based on the localization. So and also to avoid the trigger factors. So the education is very important from many points of view. I don't know if you, Hassan or Markus, you have other idea about this topic.
Yes.
I'm a little bit critical about the trigger factors. In the first years of my clinical practice, I also followed these trigger factors and advised my patients to avoid the trigger factors. However, avoiding most of the trigger factors reduces the quality of the life, because the trigger factors in many cases are everyday events. Some of them you can't avoid at all, like weather changes. Some of them are very difficult to avoid, like stress, and others just make life fun. And so I think it's important to educate the patients about trigger factors. And if there is a trigger factor you can easily avoid, like estrogens or ACE inhibitors, for sure, they should be avoided. But I would not go so far to educate my patients to avoid all kind of trigger factors. So in this case, I believe we can trust the medication we have now, so patients can face these trigger factors without having an attack. I think that's important to you were talking citing the guideline, normalizing the patient's life, and normalizing means also that triggers that triggers need to be tolerated due to our treatment. At least the triggers that make life fun.
Yeah. We have 2 minutes. Do you have some questions?
I think the question is from our chair, Francois, is it?
Yeah.
Yeah. I think the education patient is very important, but it depends of the countries, I give you an example from the Greek model, what I very impressed by this model in Kreak in Grenoble. So the model is very interesting, and it's very gone. They have a good result. So they organize the session with patient and the physician. So when they explain them how how can we use the treatment, for example, by using self-administration. And when patient comes to go abroad, they bring with them medication. So I think that it's very important, but it depends on the countries. When you have great counties like Algeria, for example, we have more than 50 departments, So it's not. I think also they use the Zoom also with patient to explain them when they have problem. And one patient, for example, comes to do a surgical or go to the procedure dental, they explain them. So I think that the education patient is very important, because thanks to this education treatment, the number of the crisis is going down. And by using the good treatment, they know how they done when they have a crisis, when they live abroad, when they live so far from the hospital. So grown up, I think that I have been in grown up for many times. Grown up in France, educayak is, I think this is model to follow.
Okay, I think that our time is over. I'm sorry. I had a question about the affordability of the future therapies, but for the next time, the next webinar. Okay, thank you very much, Markus and Asen, and I hope that the webinar was clear and useful for our audience. Bye-bye.
Thank you.
Thank you so much.
See you next time.
Thank you, Hassan. Bye-bye.
Bye.
See you next time. Thank you. Bye.